Director of Policy at the King's Fund, and I'm the chair today, so I'm hoping that I'll be able to get us through what's quite a packed agenda, hearing from several members of the Commission, and then a chance for many people to ask questions as well before we'll finish at 3:30. So why we're here today is that Health Devolution Commission has been working for the last 6 months to really be thinking about a major challenge for the future of our health and care system, to think about how do we want to have a health and care system that genuinely supports population health and well-being, rather than a system that's about treating sickness and people who are unwell. The timing of the launch of the report has ended up being even more opportune because the COVID epidemic has really brought into sharp focus the issues we have across the country on very wide health inequalities, a real difference in experience people have in the opportunity to live a happy and healthy life. And we very much hope that today's report is a really important contribution to the debate about how we should move forward as a healthcare and population health system. So I'm absolutely delighted to welcome you to today's launch of the report, Building Back Health and Prosperity. I'll just do a brief bit of logistics and then move on to the panel sharing some of their reflections on the work to date. So this is obviously a classic bit of launch, but you talk about slightly different things on logistics in a virtual call. So I'm used to talking to people about Wi-Fi codes and fire alarms when it's a physical conference. That is all your own personal responsibility today. But what I can say to you is please do tweet if you feel that you want to. The hashtag is #HealthDevo. In terms of how the structure of today will go, I will ask the panel to share some reflections at the start. I'll then move to questions from our colleagues from the media who are in attendance, and then we'll have a chance towards the end for any other audience members to ask any questions. I'll explain the logistics of how audience members can ask questions when we get to that stage. The other thing I need to just offer an apology right at the start is that Andy Burnham is due with us. He unfortunately has not been able to join us at 2:15 because he has some local action taking place in Greater Manchester, but he will be joining us, we hope, in about 15 minutes or so. So we're slightly rejigging the order of things today, but you will absolutely get a chance to hear from Andy and ask questions of him throughout the rest of the session. With no further ado, I think I will hand over to our panel. Now, the key role of a chair is to try and keep everything running to time, and it must be said I'm slightly daunted with 3 politicians being on a panel and trying to keep them running to time, because all of my experience when I was a civil servant working for them is they never did what I asked them to do. So we're going to see if today is any different, and if they do follow their instructions and just speak for a few moments each. So I'm absolutely delighted to introduce first Norman Lamb. He's obviously a former Care Minister in the Department of Health and Social Care and a really important leading figure still in delivering health and care services, particularly in mental health. So Norman, over to you, please. Thank you.
Well, thank you very much indeed, Sally, for that introduction. And I wanted to start also by thanking Steve Barwick and Phil Hope for the amazing work that they've done in driving this whole project forward, in doing the writing and in sort of coming up with the idea in the first place. It's been massively appreciated. It's also been great to have a sort of reunion with former colleagues from across the political divide. Phil himself, Andy, Stephen and Alistair, we've all worked in the past close together in many ways, but what I think has been telling is that we've all found ourselves in complete agreement over the conclusions of this project. And so I think, you know, as you indicated, Sally, this is quite a pivotal moment as we emerge from the COVID crisis. First of all, we've seen the sort of scars caused by this COVID crisis and the impact in particular, the disproportionate impact on certain groups within our society, disadvantaged groups, people from Black and minority ethnic communities. We've also, of course, have to recognise that the NHS, which has in many ways performed heroics through this period, but has faced an enormous challenge and now faces, in a way, an equal challenge with the extraordinary backlog that it now has to try to cope with all of the impact on cancer diagnoses, on length of time people are waiting and so forth. and we have seen the social care system, all of the fragilities of the social care system exposed in a way that perhaps we haven't seen before. So now is the moment when we have to work out collectively as a country, as a society, how we deliver a well-functioning and effective health and social care system, but also how we drive better health in our communities and how we use that to promote regeneration in our communities. And I think there are, in a way, we are at a fork in the road. There are two different directions that we could go in. There will be those who are tempted by even more centralisation, by trying to grab more political power, taking power back from NHS England to try to drive everything from Whitehall. But we all know from our collective experience in the Department of Health that you can't do it, that it won't ultimately work, and that it won't drive good health in our communities. So our alternative prospectus, in a way, is one that involves the devolution, not of just the delivery of a healthcare system, but of health policy, how we manage to promote health and well-being in our communities and how we use that to promote regeneration. And the great prize, I think, and it's seen in exemplars such as Greater Manchester, and we hopefully will hear from Andy later on that, but the great prize is that at a locality level, we can bring together housing, employment, the criminal justice system, the social care system, the NHS, the education system, to work together to particularly address the causes of health, ill health and health inequalities within our communities. And so our prospectus is a deliverable prospectus if there is a political will to deliver it. And I think we've seen a hint from the experience of other countries that more devolved systems appear to work better, particularly when faced with the sort of crisis that we've been through over the last few months. But it's not, for me, good enough just to think about the big metropolitan areas, the Greater Manchesters, the West Midlands. I want the benefits of a real locality focus on health and prosperity to benefit places like my own county of Norfolk. This should be available to all communities across the country. And I think that is also a prize that's worth pursuing. And the final point I'd make, Sally, is that we're not advocating the replacement of a sort of national bureaucracy with a local remote bureaucracy. We're proposing, and there was complete agreement about this, a system that empowers people, that empowers communities, patients, giving patients power, personalisation as we call it in the jargon, involving third sector, involving the private sector, genuine collaboration in the interests of the health of our communities. And that is what is attainable if we learn the lessons from the last few months, if we learn the lessons from many decades of a divide between health and social care. And the final point I would make is that alongside this, we do now need to resolve the problem of the funding of social care. It needs to be properly funded, but it then needs to be integrated fully, single budget for health, for public health and for social care. And if we can achieve that, then there will be something very special that we can achieve for our communities. Thank you very much.
Great, thank you very much, Norman. You were always one of the better behaved ministers, so you've come in your time limit, so thank you very much. And really important points there about how if you really want to improve health, we need to move away from a kind of thinking about institutions and bureaucracies and really be basing that in communities and in how do you improve the lives of people that and health and prosperity go hand in hand. So thank you very much. I'm next going to turn to Stephen Dorrell, who will be very well known to all of us as being a Secretary of State even before my time in the civil service, and then obviously a leading figure across health and care for several decades now. So I'm absolutely delighted to hand over to Stephen. Thank you.
Thank you much, Sally. My standard introduction for myself is to say that I was Health Secretary in Gladstone's second administration, so you need a very long memory to remember that. But I think it's important to be clear what this report is and what it's not. What it's not is a prescription for the future management of the National Health Service. What it is a prescription about how we can address priorities for health, in which, of course, the NHS has an absolutely key part to play, but health policy is something that cannot simply be delegated to the National Health Service. This debate between central emphasis, local emphasis, it's as old as the NHS itself. It goes right back to the arguments in the Labour cabinets of the 1940s between the Bevan, who wanted a centralised system, and the advocates of a more localised system that existed at that time. So given that debate within the NHS between central leadership and local ownership is as old as the NHS, the key question really that we faced as a commission, and I think is relevant in this discussion this afternoon, is what's different this time? And I think there's something really very important that's different this time. Those of us who've regularly advocated more localized decision-making have, I think, always made a mistake when we focus too much on the NHS aspect of local decision-making and not looked across other local public services, which are the core function of local government. Most obviously social care, but this is not just about health and social care. It's about the full range of services for which local government is responsible. How can it possibly be right, for example, to have a paediatric service in the NHS that is divorced from the education service where children come to school every day? Child health divorced from education is a barrier that makes no policy sense. And what's become this insistence, this urgent requirement to remove the boundaries between different public services serving people in the same place has become, of course, has come in very sharp focus during the COVID era. And this is one of the things that I think as a commission has encouraged us to move beyond just making reasonably familiar arguments for more localized management, and to stress that this is an urgent requirement now to build public services back in a different model that avoids the kind of breakdown that we've seen over the last 3 or 4 months, in particular, clearly, on acute hospital discharges into social care. But it isn't just about that. The current debates about reopening schools are fundamental, not just to education policy, but also to health policy in the months and years immediately ahead. And so I'm delighted to see Andy's now joined us. But as people who were political opponents when we held office at Westminster, it's one of the joys, actually, of life since Westminster has been that I've appeared regularly on platforms with Andy. And that's not to say we agree about everything. I don't think we do. But we absolutely do agree about the centrality of building a more coherent, joined-up version of public services accountable to local people with the focus on delivering better health outcomes. That's what health policy ought to be about, not the bureaucracy of the NHS, but delivering better health outcomes. And if we're focused on doing that, outcomes for residents of care homes, outcomes for people who shouldn't be in care homes anyway because they should be being supported at home, outcomes for children, outcomes for working age adults who rely on the full range of public services. That's the focus that we are seeking to draw out in this Commission report. And if we can use the learning from the COVID experience to make that case with a greater urgency, then we shall have done something hugely valuable. Thank you.
Great. Thank you very much, Stephen. Really important points about needing to think beyond healthcare and really be thinking about health, and recognising this is now an agenda where there's an awful lot of political agreement, which is really helpful. So Andy, it's great that you've finally been able to join us. It's almost like you've got like a proper day job that might be keeping you busy at the moment. So thank you very much. We rejig the order obviously to deal with that, but if it's okay, I will come to you next, and then we'll move to Alistair and Linda for final comments before then throwing it open to questions. And I'm hoping we'll have quite a few questions because we've got 63 people joining in this conversation at the moment, so I'm sure they will be thinking of challenging questions to all of you. So Andy, over to you, please. You kind of need no introduction, so over to you.
Well, thanks very much, Sally. Sorry to be late with you all this afternoon, but it's brilliant to have so many people tuning into this conversation, because I think this is an idea whose time has come and has been made more relevant by the crisis that we've been living through. But I just want to start by saying what a pleasure it's been to be a part of this commission with Norman, Stephen, Alistair, and all of the colleagues. You know, it's probably right to start with where Stephen was leaving off. You know, we often did find ourselves the dispatch box, because I think occasionally we did sort of face each other across the dispatch box. Part of the problem with the way we run things in this country is that running it all through Westminster means you run everything through the prism of party. And that is essentially a divisive approach. And devolution breaks out of that. Devolution is fundamentally about place. If you give power to a place, you create the conditions for people across all political views to come together, because the place is what people have in common. And I think, you know, it's a precursor for creating a better kind of politics in our country, a better way of running things, of involving people, building from the bottom up. It's a unifying force, not a divisive force. And I think devolution is probably the one thing, if you look around quite a divided political spectrum at times, devolution is something that all political parties and people in prominent positions are saying, actually, we agree with that. So let's take that agreement and move forward with it, but particularly look at it in terms of what it can do to improve the health of the nation. So, Sally, what I wanted just to say in my contribution was to pick out 3 things that have demonstrably not worked in this crisis, and then to explain why I think greater health devolution is a big part of the answer to building back better coming out of this crisis. So the first thing I would point to is how a centralized approach to delivering simply doesn't work. It doesn't connect enough to what's happening on the ground, and it becomes inefficient and frustrating. And I've certainly felt that in my position as mayor. So I could kind of point to a number of examples. PPE in the early phase of this, where the national procurement effort just simply wasn't sufficiently responsive to what people were calling for. But testing, you know, we've still had a situation where contracts set up to deliver the Pillar 2 testing. It's taken months to get the results of that test data integrated into local systems. And that has been hugely frustrating. Or another example, the volunteers, the understandable call to say, let's have some NHS volunteers. That just kind of hoovered up a huge number of people who wanted to help into a national waiting list, leaving the community organisations and community hubs that councils were running without volunteers. And it's a kind of classic example that an overly centralising mentality actually kind of takes focus away from where it needs to be and doesn't deliver. And I think that's been illustrated by the time that we're in, and the rebalancing of NHS test and trace that's been announced in the last few days, I think, is finally a recognition of that. National has a role, local has a role. It's about getting them in the right balance, and that at times has been missed in this crisis. So that's number one. Number two, I think hopefully these things are not contestable, because I think they've been self-evidently laid bare, is the gap between the NHS and social care. For all of the talk of integration, it's cavernous, if we're honest, in terms of the capability of both of those systems, the way in which staff are treated in both of those systems. This is a massive divide that probably has got even wider in recent times when we've had a funding settlement that has helped the NHS keep its head above water, where the same could not be said for local government. And you know what we have seen here, when we saw the way in which hospitals were coping in the height of the increase in infection compared to the way care homes fared, that obviously, that I think was laid very clearly in front of the country, and people could see that this wasn't a system that was operating with equal capability at either end, from home and care home all the way to hospital. It was very, very unbalanced. So that's the second thing I would say is self-evidently true. The third is that, and it's in many ways a bigger point, that the virus has hit the poorest communities hardest, and it's clear that those communities have the least resilience when it comes to a health crisis. And you know, if we could debate why that is, well, I would point people to the report that Professor Sir Michael Marmot delivered in February this year, which was a 10-year-on report from his original report. And I think you find the reasons why our poorest communities have been hit hardest there, because it's about the quality of people's work, the quality of people's housing. And in many ways, it's that point really that kind of brings me to the sort of big observation I would want to make, in that I think Stephen was saying this, and I agree fundamentally with him. Health is built in homes, in families, in communities, and yet we have a system that obsesses on hospitals as opposed to those things. And health policy is very much concerned with treatment rather than prevention. The way I've often described the different roles I've held as Secretary of State for Health and now Mayor as the first city region with a degree of health devolution, the way I would describe it, the difference is this: as Health Secretary, it's possible to have a vision for the delivery of health services, but as Mayor of Greater Manchester, I can begin to have a vision for people's health. And it's a very big difference between those two things, because as Stephen said, when you break down those Whitehall silos and you ask people to work differently to support a health in all policies approach, I think that is where you create the conditions to build health resilience in our communities. I'll give you, a very obvious example: the early years, which is crucial to building that health from the first days of life. You know, we are developing a program in Greater Manchester that is about single unified public services, and we have created a system where it's basically a whole team around the child, working with community, families and community organisations. That, I think, builds health in a way a top-down, target-driven regime from the Department of Health never, ever, ever will. So I would say health devolution can provide an answer to that overly centralised approach that isn't working. We have been buying our own PPE in Greater Manchester through this crisis, and that's one area where I think we have performed better than elsewhere because of our good fortune in having a degree of health devolution. We've led calls for the rebalancing of the test and trace system, and I'm pleased the government has listened to us there. We ran a mutual aid system for PPE across acute hospitals and social care providers. Again, the benefits of running this as one system. And while we haven't been able to protect all of our communities from the virus, and you can see that in the news today, we have done some outstanding work protecting our rough sleeper community by having a joined-up approach where mental health teams are working very, very much with our housing and homelessness teams to provide a wraparound support. And Greater Manchester, I think, has made great strides on that because of the approach that we take. So I think if you're to look at what's gone wrong in the pandemic and you're then to think, well, how do we build back better? I think you would come to health devolution, as this report says, as a big solution. Empowering people from the bottom up, breaking down the silos between those Whitehall departments, beginning to integrate health and social care. We have improved standards in social care in Greater Manchester, even though we've not had increasing budgets. And that's because we're using the capability of the NHS to lift up our social care system. And we have fewer care homes rated inadequate today than we did a few years ago. We've got rid of the 15-minute visit culture in social care, but there's only so far that you can go. Personally, I know this report hasn't dealt with funding, Sally, but let me just say something briefly about it. I would favour, if we're to take this to the nth degree, I would say that we need a single system approach to health and social care on NHS terms, and I personally would like to see a funding solution that supplements a devolved model in that way. I'm sure there are probably different views amongst our commissioners, but if we could first agree about devolution and a truly integrated system that links health to housing, education and the early years, then I think we've got the right foundations to begin to consider a new funding system for social care. And that is agreement between the politicians on this commission. And in these divided times, any form of agreement of that kind is precious. We need to capture it and build on it. This report lays that out very clearly. I'm proud to have been involved in it. And Sally, I will, on that note, hand back to you.
Great. Thank you very much. Thanks, Andy. And it's really useful to hear your combined reflections on having had a national role and now a local devolved role, really important. And I think the thing I'd add to that is obviously, yes, COVID-19 has absolutely hit our poorest communities hardest, but actually that's pretty much the same case for any illness across the country. So we always see that the burden of illness falls on those communities. So this is why it's really about how we can fundamentally think about health and well-being rather than just about sickness, which is absolutely critical. So thank you. I'm now going to move on to our final couple of reflections from our commissioners. Alistair Burt, absolutely delighted to welcome you onto the panel. Alistair, you are the most recent holder of political national office. So you're kind of, if you like, the most recent former. So really delighted to have you with us, and it would be great to have a few reflections from you on the importance of devolution for health.
Thanks, Sally, very much, and a very warm thank you to all those who've participated in the Commission and to colleagues who've worked so hard on coming to the conclusion that we have. I very much appreciated both being asked to join the Commission and taking part in it. I don't want to speak for very long. I know people are anxious to get onto questions, and I don't want to repeat so much of what colleagues have said. It'll be no surprise to anyone who knows me and my approach to politics that looking for a collaborative way of handling something so important to the nation as its health and social care is something that appeals to me and has always appealed to me. And I think two things have led to the opportunity to concentrate on an aspiration that people have long had. All of us who've been involved in health have known about the importance of prevention as much as treatment, and have also recognised the importance of environment to everything connected with health. And for one reason or another, it's always been too difficult to do in the past, or it's never been the right time. The two things I think have made sure this is the right time. Firstly, the government's stated commitment to levelling up, a government with a healthy majority and clear aims in relation to this. And here is an opportunity to achieve that. And secondly, of course, the crisis that people have mentioned, which has shone quite a fierce spotlight both on the things that the NHS and the care system do very well, and the things where it has been shown that actually more could be done. So this commission, though it was never intended to deal with something like a pandemic, has fallen at just the right time. My reasons for support for the conclusions are these. I mean, firstly, I think in terms of the great question to be answered, do we centralise more or do we follow through with devolution? I think we're very clear on what the answer to that should be, and it is to follow the line of devolution. And all of us who've had experience of dealing with health know how often we have gone to local areas and said, why do you do this better than somewhere else? Why doesn't this work as well in other places? What is it that you are doing? And we want to see the best be the exemplar for the rest. I think taking that opportunity has been really important. So the great question is dealt with by way of the fact that we must move to devolution. But secondly, there is no prescription here. We all know that the detail is not easy, but if we're determined on the outcome, then I believe that what we're doing can make a contribution to what the government is already thinking. It's not posed, as far as I'm concerned, as a challenge to government. It's posed as a contribution to thinking that government must now inevitably follow, not just because of its manifesto commitments, but because of the situation we found ourselves with COVID. And therefore, we do have an opportunity to do something about it. I think, thirdly, in particular, the devolution model plays to a strengthening of a country which will be increasingly defined by the strength of its local partnerships rather than just the centralisation. We've all lived with this criticism and difficulty in the United Kingdom. And all of us, particularly in opposition, have stressed the importance of locality and local decision making, and then quietly forget it when we get into government. This is a time to challenge that. More local decision making does mean that from time to time, areas will choose a different course than government might have wished. But as long as you've got strong national standards, that's not wrong. And to get into our discourse a better relationship between those with differing views who will have to come to a conclusion together to make things work, I think is absolutely, it's the right time to be doing this, and health and social care is the subject. And just lastly, briefly, as you indicated, Sally, with the most recent experience of the formers in government, it was me who had to communicate to Andrew Dilnot the cabinet decision that his proposals for social care funding were not going to be followed by the government in 2015. And of course, that left a gap which has yet to be filled. And like everybody else on the panel, I feel very strongly that although the funding of social care is not the fundamental issue in this Commission paper, it can't be avoided. And there has never been a better time to work together across the parties, across government, across the nation, to find an answer to something that's been crying out for it for too long. And this paper, this Commission makes a contribution in all those areas. That's why I'm really pleased to back it with colleagues. And I think it's a great opportunity for the government to support it and work with it, because the detail will not be easy. It will require a strong response from government working with its partners in local government, but there's never been a better time to do that. Local government can and should do more. And I think with the sort of representatives we've heard from and those who are out there, there's a good chance of achieving this in the future. Thanks, Sally, very much.
Great, thank you very much, Alistair. I'm now going to move to our final panelist who will offer some reflections, and then we'll start with questions. So we've so far heard from politicians about health and care, and that's because health and care in this country is inherently a political thing, always has been, and it's also a political thing that is often has a lot of disagreement in it. So actually the fact that we have politicians from all different parties and all different aspects of politics coming together to say they believe that devolution to support health and prosperity is the way forward is really, really important. But this is more than about politics and politicians. So I'm also really pleased that we're going to hear next from Linda, who is a clinician with a huge amount of experience about how to deliver good quality services and improve the health of the population. So Linda, over to you for a few reflections, please.
Thanks very much. Yes, I'm not a politician. I'm a consultant physician by background, although I've worked right across the NHS in both regulation and various other leadership roles. But I was coming at this as a clinician, and I, as a doctor, I've cared for many older people and people with chronic conditions who need both health and social care. As an individual, it can be really hard to navigate your way through the system at the moment. It's very complex, there are lots of barriers, and the two major systems, health and social care, just don't work well together. People want joined up care. We've said not just in health and social care, but the other modalities as well. And we've been talking about integration of health and social care for decades. At least I have. I'm trying to make it work on the ground, picking your way with individuals through the system to try and support them to get the care they need. So the question is how to achieve it. And I think that's why the Commission's been so interesting, because we've brought together politicians, clinicians, providers, patient advocates, and concluded that devolution to place is the way forward. And as Andy said, it's not just to increase integration between health and social care, but those other modalities of employment, space, housing, etc. Very much based on thinking about Michael Marmot's work. So it seems to make sense to me, as somebody who's struggled with these issues in a very practical way with individual people over many, many years, that we really do need a way of bringing things together, breaking down the barriers so that we can have real person-centered care in whatever way, so that the person themselves doesn't experience the barriers, and we can give them a seamless service. So that's why I have been pleased to be part of the Commission and to work with my colleagues, all of us bringing a different perspective, but I think we've moved towards a common conclusion. Thanks.
Right, thank you very much, Linda. It's really, really helpful reflections about the importance of thinking about this from a patient and person perspective. So that's the end of the formal kind of presentations and reflections. So we're now going to move into a couple of sessions. One for questions from colleagues who work in the media, and then we'll move on to a wider set of questions. Just before we do that, a few, well, one reminder and one request, please. So a reminder, if you are tweeting, use the hashtag #HealthDevo. For those of you on Zoom who have perhaps not completely obvious Zoom usernames, if you could change them so I kind of know who you are and who I'm calling on, that'd be really helpful for me just to be able to manage the questions. And as I say, we are going to go to our media colleagues first, but do not worry, we absolutely will have time for everybody else. So don't kind of feel like you frantically need to be typing your questions at this point. So in terms of managing the questions, what I'm going to ask people to do is, you don't need to type your full question in chat. I think that can take a bit too long for you, and it takes a bit too long for me to read it. So if you have a question when it comes to that point in the agenda, please do just kind of put in the chat that you've got a question, and I will then come to you. And we'll do that same model with any media colleagues. So if any media colleagues do have any questions they'd like me to come to you, then please drop that as a note on chat, and I will then come to you. And how this will work is, when you are asking a question, if you turn your video on and your audio on, you will be visible to all of the audience as well as visible to the panel. So let me, as I say, give our media colleagues a couple of minutes to see if they have a question to ask. And apologies that there is probably quite a lot of background noise, because definitely the thunderstorm or the rainstorm is hitting me. It's making no difference to the temperature though, so I'm slowly but surely melting here. So let me just double check. Sorry, I'm having a slight okay, let me just double check. Right, if I'm just going to give our media colleagues another sort of few seconds to flag if they would like to ask a question. Sorry, can I just check, Steve, where you're messaging me? Is that because?
I think there's somebody from the FT, I think Anna from the FT, and also Aine from PA, who were both indicated before they'd like to ask questions. So perhaps we could.
Well, as I say, I'm going to
Heather Jameson, and Heather Jameson also from the MJ is on the call, so I'm sure she'd like to ask something.
Okay, so just because I'm aware of time and there'll be lots of other people, so I think I've given our media colleagues enough time to indicate if they had wanted to ask a question. So that's we'll move on. Obviously, if you do later have a question, just message us and we'll try and pick that up. But now I'll open it up to wider questions from the audience. Again, if you can please do that just by putting in chat that you have a question. We have, obviously, questions can go to any of the colleagues who you've heard from in reflections today. We also have on the panel a number of other commissioners who are part of the process. So our colleagues you haven't heard from yet: Peter Hay, Karen Mellenby is one of our advisors, and Phil Hope. So we'll kind of do a bit of a pick and mix as depending on the questions who might get to answer your questions. But I think we will start with Peter, Peter Ellis, you've been I think you were the first up to say you had a question. So if you could put your camera on and unmute and say who you are before you ask your question, that would be great. Thank you.
Hopefully you can, sorry, well, Peter Ellis, I actually, for instance, but I sent Steve a missive I'd put together because of the endemic. Someone who started in the NHS, but then spent 25 years in Canada, so became very used to devolved models because healthcare is a provincial, not a federal responsibility over there. There are 10 different systems as a result, although there is obviously the leadership at the federal level, the policy issues. But the issues I've believed in, and obviously I haven't had a chance to see the report as to whether it's addressed this, but one of the key issues, and I think this came out of Pittsburgh University, was that the key issue to successful devolution, it doesn't matter who leads it or the makeup of that, but it's to do with ceded authority and the willingness to cede authority to whatever entity is created. And that seems to me to have been an issue even with some of the devolved models we've been starting off here in the UK is there any real ceded authority that they have to use? I guess the other issues that bug me particularly as related to the endemic has been, or the pandemic, has been the cultural issues as well, because you know, it wasn't any surprise to me. The UK is actually, in terms of OECD performance, one of the worst performing of the major countries, and therefore the fact we ended up with the higher rates of mortality probably could have been predicted in some ways. And some of that is to do with obviously funding and devolution. The other thing is culture though, and we seem to have this blame culture, which does require, I would hope, some addressing in the models, and hence devolution hopefully allows the different cultures to emerge, because when it comes to adopting new technologies and actually being innovative, we have great science, but we're always the last place. And I've been chairman of a couple of major technology companies. We're the last place you would want to launch your new product because it's such a bureaucratic nightmare. And hence devolution can help that as well. Yeah, I'd just like to see how those issues will be dealt with. My view on the larger issues is, as you say, there are some policy issues that need integration, but when it comes to delivery, there needs to be a true authority with real seeded funding and capability. And that's really my question as to how that's being addressed in the report. Apologies for that.
That's okay. Thanks, Peter. Andy, I might come to you first in this question, as somebody who's sort of trying to live and breathe that sense of making delivery happen in a devolved context. Kind of what's working so far, what would need to be different from your perspective to really make it as easy as possible for you and your colleagues in a devolved system to have impact?
Yeah, so thanks, Sally, and thanks, Peter, for your question. And you know, I would agree with you. In some ways, we've got embryonic devolution around the country at the moment, and obviously we're the only place with a degree of health devolution, and it's a degree because we have a partnership with NHS England, so we're not fully in control, if I could put it that way. But the first thing I would say is you've got to obviously make a case for why you should have more before you just demand it, you know. And so we have been trying to build the authority that comes from the Greater Manchester Combined Authority with regard to some of the things that we can point to that we've used devolution to do. One is improving social care, and I'm pretty confident in saying that because I can back that up with the figures that we have seen an improvement there. Another is homelessness, and you know, you cannot tackle homelessness unless you have health absolutely kind of in lockstep with housing professionals, mental health particularly, and drug and alcohol teams. And we've definitely made progress there. So I think you've got to kind of gain authority from the examples where you can say, look, this is a better approach than we have in other parts of the country. And therefore, let us now go to the next step. It's that old question of earning autonomy, isn't it? But I think we are on that journey. But I do think we've got to see a sort of end to the arrogance of Whitehall, if I'm honest, because we see a very different approach taken by different government departments. Some who are supportive of what we're trying to do, some we have to battle quite a lot. I just think that the British state hasn't yet kind of bought the idea that people at a local level might actually do things better than they can do, sort of telling people what to do in an office from miles away. There's a problem to be got over here, trust of people at a local level, and it's under all governments, by the way. The government I was in was too fond of targets, and they were a way of not empowering the front line. And we're seeing other forms of it now. I would, just kind of really kind of say, having been a minister like others on this panel, the way Whitehall departments work with the turf wars they have and the kind of bureaucracies they create, they haven't sorted out social care. They haven't created a good technical education system or skills system in this country. They have left some of our poorest communities most at risk from this virus. So, as I was trying to say at the beginning, that way of working hasn't worked for everywhere. So devolution is to come at things a different way. And I think, if you look at what Andy Street is doing in the West Midlands, and I talk a lot to Andy, or Steve Rotherham in Liverpool, the voices of these mayors is growing all of the time. And the Mayor of London, obviously has made great strides in London over the years. It is time for the UK to adopt this more federal model. We are both politically the most over-centralised country in the OECD and the most regionally unbalanced. And I would put it to everybody listening into this that those two things are linked, because we've had political decision-making focused on one postcode and therefore hasn't been able to reflect perspectives from all over the country. And if, as Alistair rightly says, levelling up is to be a real thing that this government sort of, a movement that it starts, you don't just level up by laying a new railway line, you level up by investing in people's agency, their capability, in their communities. That's how you level up. And I think devolution is beginning to show that it can do that. It can break down the silos, and it can make departments think of places rather than policies or parties, if I could put it that way. And I think we're ready for it. This pandemic has really kind of shown that the old way of doing things hasn't worked for a lot of people in this crisis.
Great, thank you very much, Andy, really helpful. I'm going to next come to Justin Madders, and then after Justin to Charlotte Aldrich. So Justin, hopefully you should just be about to appear on the screen for everybody. Are you there, Justin?
Hi. Yeah.
Hi.
Right. Oh, thanks very much for I've heard so far. I've been very interested. I think the general question I have is really about geography and accountability. Obviously, picking on what Norman said earlier on, his area is very different to Greater Manchester, where I think it lends itself, I think, quite easily to a model where you've got a direct line of accountability to the elected mayor. But just wondering how easy it's going to be in other places where there isn't that sort of focus. And also, and I think this is something Andy's probably touched on a little bit in his last answer. Obviously, governments do have their own performance targets to set, and obviously at the moment we're doing pretty poorly across the board for understandable reasons. But would the panel envisage each area having their own sort of standards as such of what they would expect to see from the big trusts in terms of waiting times, etc.? Or would that, I mean, do you think that would be too much of an ask to expect Whitehall to relinquish that kind of control?
Great, thanks, Justin. I think on this, to give some panelists a bit of a forward notice. Peter, I may well come to you second, because I think particularly the different geographies and how none of them match is an issue that you've grappled with in social care and as president of ADA. So I'll come to you. But Norman, if perhaps I could come to you first because particularly given Norfolk is such a different kind of geography to Manchester, kind of how do you see some of the questions of accountability working in that different kind of setup and footprint, to pick up some of Justin's issues and questions?
Well, first of all, great to see you again, Justin. I miss our chats in the lift in Portcullis House. But I mean, you raise an absolutely critical point. I mean, at the moment, as Andy said, this is very much embryonic. And there's always a danger if we just carry on as the way we are at the moment, that there could just be a reasserting of control from the centre at any particular point. So the settlement that we need, and we need a new settlement which embeds this in legislation so that there are clear rights to govern ourselves at a locality level in this regard. But it has to work critically, as you say. It has to work for Norfolk and for Yorkshire. You know, wherever you look, the localities, there will be differences because, of course, in a rural area such as Norfolk, the challenges are different to a Greater Manchester. But, you know, in Norfolk, we look to our county. We have a county social care authority. We have a move back towards coterminosity between NHS and social care at the county level. And so you could see the basis of a unit there, which I think would work potentially very well. And, you know, we don't yet have an elected mayor. There is now talk again of whether this could happen in the future. And I'm concerned about this hope, if we just leave it to a sort of very slow evolution, there could be parts of the country that are left horribly behind. I think there needs to be some drive and hopefully a cross-party agreement nationally that this is what needs to happen to empower those localities. So yes, variation from place to place, but absolutely ensuring that every part of the country can be part of this, because the health of people and the prosperity of people in our rural counties is just as important. And we cannot just continue with what I always see as a bit of a dependency culture. You know, we can't do anything without asking permission from Whitehall, and they usually say no. And that's got to change. We've got to empower those localities to take control, just as Manchester has started to do. But we can't allow the centre to be able to just retake control.
Great. Thank you, Norman. Peter, is there anything you'd like to add to this question about accountabilities and geographies?
Looking downwards always creates a complex geography. One of the features of this report is that we've put a great deal of stress on working from communities outwards. And so actually community involvement, community structures at that very basic level, and how to engage and empower and work from there. And I think how that sits with broader measures of accountability are key. And the other part I would put into that is one of the features of the report too, is it tries to look beyond just a health and care paradigm. There's a really good set of circles about thinking about that creation of a healthy person rather than just delivering health services. And again, if you look at the way a whole batch of services are delivered, they don't fit on easy geographies either. So I think it's trying to come at it in a different way to create some different solutions.
Great. Thank you very much, Peter. Really helpful. I'm now, just because I'm a bit aware of time, I'm going to take questions in sort of pairs, and I will ask our panelists to offer slightly quicker reflections on answers, if that's okay. So we're going to go to Charlotte Aldrich first, and then to Paul Burstow. So Charlotte, you're up on screen already. Great. Hi.
Hi there, Charlotte Aldrich from the Centre for Progressive Policy. Just a quick question about the idea of levelling up powers and devolution arrangements. So the idea being that wouldn't it be great if all places were to get the kind of devolved deal that GM has? And whilst I think that's great in theory, a lot of places actually themselves said, well, we don't want that. We don't feel like we're ready for that. We don't necessarily have the capacity to step up to that. So this is just a question as to how we actually increase the appetite within places themselves to take on this level of responsibility and to embrace the level of opportunity that could come about if they did.
Great, really good question, Charlotte, and apologies. I have an absolute monsoon happening at the moment, which I'm sure is creating a lot of noise in the background. I think quite a lot of different panel members might have something to say on this, but I'm going to go to Stephen Dorrell first, if that's okay, in terms of thinking about how do you create, if you like, demand from local areas for these powers, and how do you help them build the confidence and skills to have it, rather than, if you like, Whitehall deciding to gift it at a certain point in time. So, Stephen. Well,
yeah, I absolutely think that it's not right to say that the GM model should be rolled out everywhere. There are Justin, we don't know each other, but MP for Ellesmere Port, strikes me as the community there is not unlike the community where I live in Worcester, which is outside a big conurbation, but has a very strong sense of place. And so what we need is, it's to a point that was being made earlier about culture. Peter Ellis said this is culture. It's the culture of understanding that places do have a sense of identity, and we have to build on that. And it is different in different parts of the country. It's different in the big conurbations. The requirements are different. The way they work is different. And it's building, as Peter said, from the community upwards, rather than seeking to lay out of a single framework, which will work everywhere. I don't think that does work. I think it's about creating, it's recognizing where there are communities and building from those communities upwards.
Great, thank you, Stephen. I think it's a really interesting answer. Phil, are you wanting to come in?
Yes, thanks very much, Sally. Just briefly, the report addresses the last two sets of questions quite directly about how every area can design its own footprint of partnerships between health, social care, and the other sort of areas, including economic footprints, to create this new devolved approach. What it doesn't do is say, and here's the right answer for Norfolk, and here's the right answer for Cornwall, or what it says is these are the principles. Upon those principles, local areas in partnership with central government can develop their own partnership arrangements, which might include a designated leader, where there's not a metro mayor, in that large geographical space in the West Midlands, in East Midlands, where there isn't such a post. Those organisations, those local partners can agree this is the way that we would deliver and run this, so that we do have the clear accountability and the leadership that the locality needs, and indeed that relationship of those designated leaders, metro mayors and others, to the Secretary of State, that partnership in health, and regional or scrutiny committees that surround and match those geographical footprints are another part of the report. So we do try to unpack and answer those difficult questions directly in the report, because they were where almost we started. If this is the direction to go, how do you do it so that it's something that is that it works everywhere? And lastly, the point about national standards. Crucially, every devolved area would need to include these national standards and to deliver those, but they would do so differently in different areas. The way you achieve a standard in a rural area like Norfolk will be different from the centre of Birmingham. And that's why it's crucial that the devolution happens, to allow the local commissioning, management, delivering of services to achieve both local ambitions to meet the local population's specific demographic needs, and those national targets, because we're a national health service, can be achieved through a blended suite of those targets locally in each devolved area. So those real critical questions about how this might work, we unpack in pretty much detail in the report. So I hope people get a chance to look at that and then take it forward. And I specifically would argue that although every area I think should be on that journey to devolution, some are going to want to go faster than others. So we shouldn't be held back. Those that can go farthest, others can learn from that experience. But that At one level, we thought, well, maybe every area should be able to make its mind up. At the beginning, we were thinking that way. I think the COVID pandemic has said, this is no longer if, is it a good idea, shall we, shan't we? The pandemic has said, you've got no choice. If we're going to restore our health and social care system, if we're going to deliver better health inequalities and better health well-being for people, and if we want to link that all to economic prosperity, as the pandemic is demanding, then personally I don't think it is a choice. People have got to say, we've got to grasp this and we've got to take it forward.
Great, thank you very much, Phil. It's really helpful. So I'll come to Paul Burstow in a moment for his question, but then also just to flag that after that I'll come to Alison and Ben for your questions as well as the next pair. So Paul, you're now up on screen and you're adding to the slight trauma for me of these are all of my former ministers all in one virtual space. So you're very welcome, Paul, obviously, despite me saying it's traumatic. It's lovely. Over to you.
I thought I was here to provide the therapy, but anyway, thank you very much. And I've only seen the summary report and I've enjoyed listening to you sort of outline your aspirations off the back of this work. And I think it is great to see how, starting from different perspectives, you've come to a set of solutions and approaches, which I think are really the potential common ground for building what comes next. So my question is about the language of integration. And how many sins that word can hide. And I guess my anxiety, and I say this from a sort of perspective of the Social Care Institute for Excellence, is that how do we avoid integration simply becoming the takeover of social care by healthcare? How do we ensure that the sort of vision that Stephen and Andy and Norman have talked about of recognising that healthcare is not created in our healthcare system, it's created in our communities, in our homes, in our workplaces. How do we make that a central driving purpose of the devolution agenda and not simply hand social care over as a sort of ancillary service to help get people out of hospital quicker?
Great set of questions there, Paul. I think, and I'm slightly kind of trying to think through, I think I might come to Alistair first on that question, but then Karen, I wonder if I could then come to you to give a perspective about how kind of mental health services as part of this broader picture around integrating services versus thinking about health as a whole, your perspective there on how you can make it genuinely that bigger vision rather than a kind of an integration of services. Okay, Alistair.
Thanks, Sally, and thanks, Paul. And it's great to be in touch with you again. Thanks for taking part in all this. A couple of things come to mind. One of the things we've not spoken about very much on this particular call, of course, has been the problem of budgets. And we all know that one of the issues between different elements of the healthcare system has been people looking very hard as to whether it comes out of their budget or someone else's. And decisions on social care have often suffered from that. And I think one of the things that we probably all feel about very strongly is we need to move away from that. And I don't think you can deal with the social care aspect without involving the responsibilities of those for social care in an area, in connection with the services, with other services being provided that support those in social care. And it's got to be done in such a way that people are not forever thinking about, well, can we push this off into somebody else's budget to make sure that we retain money for our own purposes, etc. And that's why I think the integration is clearly a good idea. I also agree, in response to one of the earlier questions, with a degree of flexibility. I said right at the top in my remarks that I noted that we couldn't come up with a prescriptive, detailed answer in this Commission report, and much of the detail will have to follow. And it seems to me, to quote a familiar phrase, one size won't fit all, and there will be a different approach in different areas. That's where the flexibility should come from. National standards, absolutely. The N in National Health Service has got to mean what it says, but getting to the point of ensuring those standards are met by recognising that local delivery is possible, and working with those locally elected representatives and with the professionals working in both the NHS in acute care and primary care, and also in social care. And again, we haven't spoken much about mental health and mental health care that will be necessary there. Getting the right degree of cooperation between them seems tailor-made for what it is we're proposing. But the work to be done in creating that flexibility and having the different sizes that will fit the different needs is still to come. But that's how I think we avoid the sort of problem of being of a service like social care simply being dictated to by others, Paul, and I hope that's a helpful observation.
Great. Thanks very much, Alistair. Karen, over to you.
Yes, thank you. I mean, Mind has been really pleased to act in an advisory capacity to the Commission and welcomes the report. I think what we've been able to bring is our reflections on both the importance of national targets and national leadership, in particular with mental health. Our starting point has been very much behind physical health, so that's been very important. But the reason we also sort of really wanted to explore devolution is the opportunity for really genuine partnership working with a whole range of stakeholders at community level. So whatever form health devolution could take, as long as there's a real commitment to work in partnership with communities, with the voluntary and community sector, with the private sector, with health providers, social care providers, then you can start to potentially break down some of those silos. We know certainly from mental health that there's so much that impacts on mental health, and therefore the solution to better mental health can come from a whole range of providers and sectors, not just health as a solution or social care as a solution. So therefore, if there's a genuine commitment from leaders of devolution to work in partnership, to listen, to look at those assets that are there in the community, to work to build capacity and different solutions, then we see that as a real opportunity.
Great. Thanks very much, Karen. So very much reflecting that health is about mental and physical health, and this is a big opportunity for local areas to think differently in their communities about how they support both to prosper. Great. So I'm next going to turn to Alison Morley and then Ben Powick. I suspect this will be the last pair of questions we'll be able to do, so I will repeat to my panelists, if you can be short and snappy with your answers, that would be great, because we are coming to our final few minutes at the moment. So Alison, over to you, please.
Thanks, Sally. I wanted to ask the panelists about what we have in an apparent divergence between arguments and policies around health devolution and wider devolution. So from the NHS, we have the long-term plan, which sees health devolution into the 5 regional NHS EI areas and increasingly integrated care systems as being a model of devolution. But that model of devolution doesn't, in many areas, doesn't actually fit or overlay the sort of wider devolution of combined authorities. And we know that there's a forthcoming white paper on wider devolution. And my understanding is, I don't know whether you have any more insider knowledge, my understanding is that doesn't cover health devolution at all. So my question to panelists is, how can we ensure that these two, as we've said, incredibly interconnected areas that are becoming more divergent in their policy direction, how can we bring them both together again?
Great, thank you, Alison. I'm going to take Ben's question at this point as well, and then I might get panelists to reflect on one or other or both questions. So Ben, over to you, please.
Thanks, Sally. Hi, I'm Ben. I'm from the Royal College of Occupational Therapists, and I guess my question, sort of following on from some of the great conversation about public services being key to work alongside the NHS. So occupational therapists in particular play quite a key role in keeping people in their homes, because I think home care has been quite overlooked when you think of the crisis in care homes that has obviously been dominated in the media over the past few weeks and months. But obviously, whilst professions like ours and others are quite keen in resolving this, the workforce challenge is something that's constantly in the background, because whether you think of nurses, OTs, dietitians, this is something that isn't being resolved nationally at great speed. Do you think this challenge that can be solved by more local decision making?
Great. Thanks, Ben, and thanks, Alison. So, so we've got two questions there. One about how best you can marry potentially different agendas around health devolution versus general devolution, and this I think comes back to some of the questions earlier about different geographies. So I think I will come to Andy for that, because you are sort of living and breathing trying to make sense of all of that. And then on the workforce challenge question, and particularly how we can make sure does local decision making help develop the right workforce strategy. Linda, if it's okay, I might come to you on that, because again, you'll be thinking about what are the skills you need, the right numbers of the right skills to support the health and care system locally. So Andy, to you, if that's okay.
Thanks, Sally. So I'll just take the question about models of devolution, if that's okay. I think we need to be clear about what we mean by devolution. Just creating more regional structures within the NHS, let's say the RDAs, the strategic health authorities, I should say, that we once had, I don't think is devolution in my view. We shouldn't even kind of grace it with that title. Devolution means power given to an area where there is a degree of democratic accountability for the use of that power invested in that area, and an ability to make different decisions free from Whitehall diktat. I would say, let's be clear about what is devolution and what is decentralisation, or something different. So I would say, it's basically what we are doing through combined authorities is England's first true step in the direction of democratically accountable devolution of power, and that should be the only show in town. And to those, just to talk about the different models, let me just speak for our model, Sally, very quickly. I mean, the GMCA is the 10 councils, unlike the GLA in London, which sits above its councils. We effectively are one system, and the thing about that is it can be hard to get everybody to agree at times, but when we do agree, it means the whole of the system, public services across the board, can move in a particular direction. And I think there is a real power in that approach. And I would say, if you want coherent devolution, I think we should work more on that model, where you're integrating local authorities into the combined authority, and then the power that gets given to that combined authority allows you to break down the silos in the way that we've all been describing. So I think, beware devolution that comes in a sort of, claims it's devolution. The government are talking about creating a northern growth body at the moment. To me, having a new statutory body that we all have to go on bended knee to is not devolution. It's just, putting government agencies in under the cloak of devolution when actually they're not. And if I may, I'll just, before I leave you all, just make a final point, very, very briefly. I know you're probably running out of time, Sally, but Paul Burstow made a really important point before about, the medicalisation of social care, or, sort of top-down takeovers of social care. To me, it's about doing the opposite. Devolution allows you to do the opposite. It allows you to start with people and then build your services from there, build services up rather than drop them down on people. And to be honest with you, what I like to see in Greater Manchester is actually the values of social care sort of coming into the NHS, as opposed to the other way around. A person-centred culture sort of infiltrating the NHS, as opposed to the medicalisation of social care. How would you achieve it? I think if you reformed the funding of the NHS so that you had a year of care approach to people's funding that was integrated around health and social care budgets, you would start to create an incentive to support people in their home rather than treat them in a hospital bed, and then you would create the conditions for that's the driver that could build a very different system. Just one last thought, the difference between my old job and my new job, as I keep pointing this out. In my old job, I could talk numbers but not names, but in my new job, I can talk names, not numbers, and that's the mantra I always give to the Greater Manchester Reform Board, which brings together all of the public services in GM, and we have one conversation about priority issues, names, not numbers. And I think that says it all. When you can, operating at a level where you can see names, as we can, of our homeless community, and you're trying to devise individual solutions for those people, that takes you into a totally new realm when it comes to the delivery of public services. And actually, you're starting with the right thing, the individual, and not statistics and targets, etc. So I'll leave it there, Sally. But you know, I think let's not be sold short on devolution. It's got to be the real deal, or don't have it at all.
Great, thank you very much, Andy. And I know you need to leave us at exactly 3:30. If other audience members are able to stick with us just for a couple of minutes, I'll go to Linda for first thoughts on the workforce question. We're inevitably only going to kind of scrape the surface of that one, and then I'll just conclude.
Sure. I was just going to say, though, how much I echo Andy's view on person-centred care, and actually making sure we keep services to the individual at the heart of when we think about things. And I think if you do that culture shift, you can often actually take services on in a different way. I think if you look at the workforce issue, what's very interesting is that often the NHS and social care system within a place is often a major employer. And I think we don't often capitalise enough on that. I've just been a non-exec director in a big northern trust, both acute and community services. And we've been building linkages with the local FE colleges, with apprenticeships, with trying to get school kids thinking about careers in health and social care, to sort of feel that they can come out of a place and actually still contribute back to the place, if you like, through a professional pathway. Obviously, there's going to be mobility, but I think that we need to think very much about the, if you like, the care service industry as being a generator of prosperity within the area that it often is, and making the most of our links with education, as I say, apprenticeships and voluntaries, etc., etc. It's a big question. The people plans just come out for the NHS, and I think we'll all be looking at that and seeing how we can take that forward. But I'm sure we need to be looking locally as well.
Absolutely, and we might also hope that one day we have a social care people plan and not just an
indeed,
NHS one.
Indeed.
Yeah, absolutely.
Great. So,
or a health and social care plan.
Yeah, that would be even better. Yes,
that would be even better.
Brilliant. Okay, so thank you all very much. Apologies that we've overrun just slightly. I kind of had predicted that a panel of quite so many former politicians meant we would have lots of interesting conversations. So all I want to do for the final few seconds is firstly thank you, the audience, for being with us this afternoon, for reading the report, for providing some really good questions. If you have a question that either we haven't answered or you haven't had the chance to ask today, then please do email Steve, who will be able to give you an answer. That's steve@devoconnect.co.uk. A few more thank yous. One is to the panel today for your honest reflections, to all of the commissioners and advisors to the Commission for your work over the last 6 months. And thank you particularly to Devo Connect, who have convened us and been trying to herd the cats of all of us to come up with what we really hope is a coherent plan that does shift the debate around health devolution. I think from me, I've got kind of 3 takeaways from today's discussion and from the report. The first is to say that we all think that right now we have a choice to make as a country, which is, do you stick with a centralised route to healthcare delivery and just accelerate that model, or do you shift to a genuinely devolved approach, which is about how you build up from people and communities to health, prosperity and well-being, rather than providing services down. The second thing to say is, as Stephen said earlier, this is not a prescription for how you run the NHS. This is a prescription for how you develop good health and well-being across the country. really important that we think in that broader, different way. And finally, we're all excited as commissioners about the prize that's here that Norman talked about in his introductory remarks, about how you bring people together to really tackle the causes of inequality in this country and really start to see a step change in that. So we've been, it's been absolutely great to work with the commissioners for the last 6 months, and we really hope that you enjoy reading today's report, and that it doesn't just become a report that gathers dust, that actually it is a report that shifts the debate, shifts how people think about policy and implementation for health improvement. So we're really excited to have shared this with you today.
And thank you to you, Sally.
Yeah,
no
thank you.
As well, thank you.
And if I could just say, wish me luck, because I'm about to go downstairs and see just how big a flood I've got in the kitchen, because my back door has been open for the entirety of this thunderstorm. So if I was looking concerned at times, it was I was thinking, oh no, this doesn't sound good. So apologies if I looked a little bit odd at various points, but thank you all very much for joining us. We'll end the broadcast at this point, but as I say, any questions that we couldn't get to today because of the time, please do email Steve and we will get back to you. Thank you all very much and have a lovely rest of the day. Take care.
Thank you. Thank you very much.
Thank you very much.
Thanks, everyone.